Hi, I'm Kathleen Moore. I'm an assistant professor of gynecologic oncology at the University of Oklahoma Stephenson Cancer Center, here with Sarah Cannon Research Institute. Ovarian cancer, unfortunately, about 75% of women who are diagnosed with ovarian cancer are diagnosed after the cancer has left the ovary, either spread to the pelvis or spread into the upper abdomen. And so that's stage 2, 3, and 4. Every once in a while we get lucky and we catch an ovarian cancer early before it's spread either from 1 or 2 ovaries. And for those patients, prognosis is very good. The treatment is surgical removal of either the affected ovary or both, depending on the age of the patient and desires for preserved childbearing. And then depending on features of the ovary on the final pathology specimen, how aggressive does it look? What cellular features does it have? Some patients don't require any additional therapy, and in this case we would be using chemotherapy. And for some patients we do give a limited numbers of chemotherapy cycles to try and prevent recurrence. But for those patients, prognosis is very good and cure rates are high, about 90%. Once the cancer has spread from the ovary, those statistics decline, unfortunately. So treatment for advanced ovary cancer, any spread beyond the ovary, is one of 2 things. We prefer to operate first. So we take someone to the operating room. We will remove, in most of the cases of advanced disease, both ovaries. The uterus comes out as a part of staging. We remove something called the omentum, which is this fatty apron that no one really knows they have, but it hangs off the colon and acts like a big sponge, and so it sucks up cancer cells. So we want to get that out. We'll do lymph nodes in the pelvis and in other parts of the abdomen. And we'll take out, the goal of the surgery with ovarian cancer is to remove any visible tumor. And so ovarian cancer spreads, there's a lot of different analogies, but I use moss on a tree. So you can picture moss sprinkled all over the bark of a tree, and you go along the bark of the tree and pick all the moss off. And sometimes you have to strip some of the bark off underneath to get the cancer out. That's what we do in ovarian cancer cases. So they're very tedious, picking out every last little grain of sand, fleck of moss. About 40% of the time, sometimes a little bit higher, it'll require resection of part of the intestines, sometimes multiple resections because it's too stuck to pick off. Sometimes we'll have to do liver resections. So these surgeries can be very big. These are not little hysterectomies, hour cases. These are very big cases, and the goal is to remove everything you can see. And then that is followed by chemotherapy. Chemotherapy is given either all in the vein, or in certain cases, some of it's in the vein and some of it's used as belly wash chemotherapy. So we'll put a special port in just under the skin with a tube that goes into the belly cavity where the cancer used to be, and we'll put chemo directly on the tumor bed. And that is not new, but within the last 5 years, there's been a very large study that demonstrated a dramatic survival benefit to that approach. It really only is indicated for patients who are left with no visible disease after surgery or very minimal visible disease. But for that patient population, what we call intraperitoneal chemotherapy should be considered as a part of the regimen. We tend to use 6 to 8 cycles of chemotherapy. The nice thing, if you can say a nice thing about ovarian cancer, the nice thing about ovarian cancers is that really, in large part, they're very responsive to chemotherapy. So about 80% of patients will respond beautifully. Their CAT scan at the end of chemotherapy will look normal. Their tumor marker, and we follow something called the CA-125 or a newer marker called HE4, either one, but they'll normalize. And then you can put patients into surveillance where you give them a break from therapy and you follow them. Or some physicians will elect to use a maintenance chemotherapy or a maintenance targeted agent, which is different than chemotherapy, but still a therapy to try and keep the cancer at bay for as long as possible. For advanced cancers, these come back. I think cure rates for advanced ovary cancer are about 12 to 15%, meaning it never comes back. But sometimes it doesn't come back for years. And sometimes it comes right back and you just can't predict. And so that's one of the struggles with ovarian cancer, is that we just can't identify those patients who are going to do very well and be off chemotherapy for years and years, and those for whom your best surgery and your best chemo doesn't get the outcome that you would like. And so that's an area of research interest that's undergoing active study right now. For patients at the time of surgery who are found to have disease in places that would be too dangerous to resect, for example, if it's deep in the liver or next to the blood supply of the intestines, of the small intestines, those are places that there's no room for error. So you can't go digging around in there to remove tumor, because if you hit something that you shouldn't, patients don't do so well. So you have to leave it. So for those patients, if you recognize that at the beginning of surgery, or if you recognize that before you go to surgery, either by CT scan, if they have disease in their lung, for example, which you're not going to operate on, then you might opt to give them, either stop the surgery or not go to surgery initially. You give them chemotherapy up front, 2 to 3 cycles, get everything to shrink, and then you go to the operating room. That, unfortunately, is probably a less attractive option. Just it allows for some resistance to chemotherapy to form. We think the best outcomes are if you get everything out first and then expose the microscopic cells that are left to chemotherapy. But sometimes you just can't take someone to the operating room, and that's okay. You have a plan B that you fall back on. So sometimes surgery isn't done right up front just based on the disease characteristics. But everyone gets the same chemotherapy. One is a drug called Taxol, one is a drug called carboplatin or cisplatin if you're getting the belly wash chemotherapy. They're very well tolerated. This isn't the chemotherapy of your parents or your grandparents where someone was never left the bed or never left the couch and vomited all day. It's not the most fun. You'd rather not be getting chemotherapy, but patients work. They still go out and about, they go to church, they have lives on chemotherapy, and they tolerate it very, very well. Women do very well. And so we have a lot of patients who have a great deal of fear about chemotherapy and what it will do to them, and really almost unanimously are shocked at how well they do and actually how well they feel once their chemo starts to work and the cancer goes away. The biggest challenge of ovarian cancer is, unfortunately, the low rates of cure. These cancers come back. For some, you retreat them with the exact same chemotherapy and it works again. And you just kind of reset the clock. Sometimes you'll reoperate on them, especially if they've recurred years later, kind of do the same thing all over again. Same surgery, same chemotherapy. You can get some additional time. It's usually less than your first interval of time, but some patients go years and years and years and years and have a very excellent prognosis. And others don't. They recur more quickly and their tumors are more difficult to treat. Fortunately, we have a large number of drugs that are very active for ovary cancer. So when our key chemotherapy doesn't work or fails to work a second time, we have many things to fall back on. And so those drugs, again, are very active and keep patients going, unfortunately, on chemotherapy, which is not the way anyone wants to live, but given the alternative, patients take it.